Well, we're back now. Turns out men are more likely to put off important health screenings. Surprise. All this month, we're raising awareness of men's health, and joining us now is Dr. Doug Dow, a urologist with Memorial Hermann. And we're going to talk about some myths associated with men's health. Dr. Dow, good morning. Thanks for being here.
Thanks for having me.
So right off the bat, first myth, health screenings are difficult and time-consuming. That's a myth.
It's a myth. Really, the point of doing a health screening is to avoid the avoidable problem. We talk about cancers, and you want to find a cancer when it's in its organ of origin, not when it's metastasized. When we look at health screenings, to do a prostate cancer screen is a blood test and a finger exam. To do a breast cancer screening is an exam and a mammogram. And to do a colonoscopy looking for colon cancer in the hands of a skilled endoscopist, it's around 10 to 15 minutes, so it's really not time consuming.
Okay. So really no excuse to not go get one, or whatever the screening is for whatever the patient. It's normal to live with bladder issues as we age. Is that a myth?
It's a myth. I'd say it's common to live with what we'll call voiding issues or lower urinary tract symptomatology. In men, we look at not only the bladder, but we call the bladder outlet, which is the urethra, and the prostate surrounds the first part of the urethra. And around 85% of a man's urinating or voiding problems is related to the prostate putting squeeze on the channel, on the urethra, giving him a hard time to urinate. Symptoms include weak stream, hard time starting, urge to pee, getting up at night. Fortunately, there's a lot of really good medications that work to help that. And there's also some really very good endoscopic or what we call transurethral procedures to help people void. And what I would say is even the most involved transurethral procedure follows the rule of 90s, which is 90% of people after the procedure go home that day. It's outpatient. 90% of people who have a catheter in get that out within 24, 48 hours. And 90% of people say, I wish I did this 10 years ago.
Wow, so it's common, you see it a lot, but it's not normal. We can treat it, we can take care of it, and it's really doesn't sound that complicated.
Correct. And the medicines now, two different classes of medicine, one which will relax the muscles in the prostate, which is the most common one that works to shrink the prostate, work very, very well. Unfortunately, the one that works to shrink the prostate takes around 6 months to work and only works on around half the people. So the mainstay is this medicine called alpha blockers, which relaxes the muscles to get the pressure off the urethra.
Here's another one. Only older men need prostate screenings, and that's a myth.
That's a myth. There's prostate cancer, which is around 160,000 new diagnoses in this country a year. And the risk factors for developing prostate cancer are sort of threefold. One is a positive family history of prostate cancer. Second is in African American men. Around 1 in 6 men will develop prostate cancer, 1 in 5 African American men, or having the BRCA2 gene mutation. A lot of people are familiar with BRCA2 from its association with breast cancer, but it also affects men and is a risk factor for prostate cancer. Now, the general public is around 1 in 500 guys, but certain subgroups, for example, Ashkenazic Jews, it's 1 in 40 men. So that type of group, in addition to the African American men and men with a family history, the American Urologic Association will state starting at age 40, men with high risk should start having a screening with a PSA, which is a prostate-specific antigen blood test, and a digital rectal exam. Starting at age 55, it's sort of a shared decision-making approach between patients and their physician.
Okay. Should men, I didn't realize, I guess the BRCA gene, that's present in all genders then in that
Correct.
sense?
That's correct. And the question is, do you have the mutation would put somebody at risk for developing a malignancy?
Okay, so is there a push at all for men to get tested in that sense?
There is. If you have a family history, it's discussed commonly. It's not always done, but it is discussed with patients, and again, try to encourage it with somebody with a family history.
Okay, let's go back to another myth. Only a doctor can screen for testicular cancer. I just assumed that I would have to go in for that. Why is that a myth?
Absolutely not. Testicular cancer really is common in men 20 to 40. And most guys 20 to 40 years old aren't commonly checking themselves. The key to doing the exam is what's called a self-exam, just sort of feeling if something doesn't feel right. The classic story is some guy's been involved in a sporting event or horsing around, something doesn't feel right, a couple weeks later, still doesn't feel right, and then they go to their doctor. And for a urologist, it's really a pretty easy diagnosis to make. Sort of when somebody feels a hard area in the testicle, that is testicular cancer until proven otherwise. Now, we confirm that with an ultrasound and we do some blood work, But really on physical exam, we can make the diagnosis.
And some of those symptoms leading up to that, are we talking about pain, discomfort? Is it constant? Does it come and go?
No, it's the classic story is a painless solid mass in the testicle.
A painless solid mass.
That feels different than the rest of the testicle.
Like separate.
Correct. I mean, you feel it just sort of when you feel the entire testicle, one part feels very different than the rest of it.
Right, and that's a good reason to go get it checked, even if there's no pain associated.
Absolutely.
Because you said painless, right?
Absolutely.
Okay,
correct.
okay, good. All right, another myth, erectile dysfunction. Some would say is not a major health concern. A lot of us guys would disagree. But honestly, how can erectile dysfunction be an indication of a serious health concern?
Yeah, so I think most guys who come to my office with that complaint think it's a major concern. But the risk factors for a man losing his erections are high blood pressure, high cholesterol, diabetes, obesity, tobacco use, sedentary lifestyle, psychosocial stressors. These are the same risk factors for developing coronary artery disease and putting somebody at increased risk for stroke. So a lot of men who commonly don't go to the physician may come to the physician or the urologist with complaints of erectile dysfunction, and we see that they haven't been to the physician. We start doing a lot of screening looking for those other things also.
Interesting. So, I mean, jokes aside, this is a serious issue that could be related to things that maybe have nothing to do with the genital area or that organ in particular. Is that
for sure? It is so common that somebody will come with that complaint of erectile dysfunction, yet they've never seen a doctor in 15 years.
Right.
And as we start doing blood work and looking into other things, it's now time to refer them to the appropriate specialist.
Is erectile dysfunction the kind of thing that happens overnight? Does a gentleman wake up and go, hey, it's not working? Is this the thing that progresses and that's why they finally went to the doctor? Because it hasn't been working so good in a while? Yeah,
with the exception of psychosocial stressors, for example, in a young guy, that's something that may happen overnight. They've had some kind of traumatic event that's happened. But in most guys who, again, these conditions, high blood pressure, diabetes, high cholesterol, don't happen overnight. So as they progress, they can create vascular changes that can also contribute to erectile dysfunction.
So I guess on the encouraging side, for men of a younger age, 30s, 40s, the better we take care of ourselves in general, the better we sleep, the better we eat, the more we exercise, less chance of erectile dysfunction showing up later?
Absolutely. I mean, it all comes down to diet and exercise and living a healthy lifestyle.
Right.
That's it. I mean, if you do those things, those give you your best chance to have a healthy, lengthy life.
And then we don't even have to worry about some of these myths so much because we're trying to do the right things. Is there a time, an age, I know it's different for different people, but where we should start talking about these issues in general? Like I'm almost 50. This is the time I should be talking to my doctor about this part of my body.
Well, most of these things start at age 40.
Right.
So really, as guys start reaching 40, I mean, everybody should see a physician sooner and have some kind of regular visit.
Right.
But really, starting at age 40, I think it's time that people get ingrained with their physician and start checking things again to avoid the avoidable problems.
And is there any reason to bring a specialist in if there isn't an obvious problem? Is it just preventative? Like, would I go see you just to check?
No,
or just to talk about
I think a good primary care physician can start the screening process. Right. Now, it's going to take a specialist, for example, an endoscopist or a colorectal surgeon or a gastroenterologist to do the colonoscopy. They will commonly send somebody to their gynecologist or a breast specialist to do an exam in the mammogram. A lot of times we will see patients to do the digital rectal exam. But again, it's the kind of thing where we have the experience more so than them because the primary care physician is taking care of so many conditions.
Right.
So
that's really the door that opens you to the rest of the world to get what you need from the medical community. Sure. Well, this has been very interesting. Dr. Doug Dow, a urologist with Memorial Hermann, thanks for your time today. Very
thanks for having me.
Good to see you.
Likewise.